Hello everyone. I would like to take this opportunity to welcome you to another episode of the Cahill Ortho Podcast. Your host, Dr. Robert Albert Cahill, is a board-certified orthopedic surgeon and founder, president and CEO of the Cahill Orthopedic Center. We are a large, multi-specialty and multidisciplinary musculoskeletal medical center in northern New Jersey and New York, specializing in orthopedic surgery, interventional pain management, rheumatology, podiatry, chiropractics, physical therapy, massage therapy, acupuncture, and high-resolution cross-sectional medical imaging. For additional information or to schedule an appointment with one of our healthcare providers, please contact us at 844-777-0910 or at khillortho.com. This podcast was conceived and designed with one purpose in mind: to educate our community of patients regarding the common, and maybe not so common, musculoskeletal injuries and conditions, and to inform them of what treatments and cutting-edge technologies may be available to treat them. Please understand that this commentary is intended only for a general audience, and not specific to any one individual's diagnosis and/or treatment plan. As such, we strongly suggest that you consult with your physician, as a proper diagnosis is only made, and appropriate treatment is only prescribed, by your doctor, and on a case-by-case basis.
Hello, and welcome to the Cahill Orthopedic Center podcast. I can't even begin to tell you how honored, privileged, and blessed I am to have today's special guest, board-certified orthopedic surgeon and member of the Cahill Orthopedic Center, Dr. Edward Friedland, as my first guest on the Cahill Ortho podcast. Dr. Friedland came out of the United States Air Force in July of 1968 and started clinical practice on August 1st of 1968. Now keep in mind, I was 8 months old at the time. Dr. Friedland served as the general surgeon in the United States Air Force and was chief of surgery at McConnell Air Force Base from January 1967 to June 1968. Believe it or not, Dr. Friedland will turn 86, God willing, and on July 31st, 2023, he will have been in practice for 55 years. Wow. God bless you, Dr. Friedland, and thank you so much for your service to this country.
Thank you.
Thank you. Thank you for being here with us today. Let's first start out by asking Dr. Friedland to tell us about his formal education and training in the field of orthopedic surgery.
Actually, my most valuable educational experience was before any of this. My high school, I went to the Bronx High School of Science, which is a school very heavily focused on science and mathematics. While there, most people are on sports teams, I was on the math team. I went on to NYU Uptown, which was in the Bronx where I lived, and majored in mathematics. Science was a minor. Psychology was a minor too. And when I finished, I was initially looking for a career in math. Unfortunately, or fortunately, as it turns out to be, there were no really good careers in math. Computers filled rooms, not microchips. And it was a very infancy industry. The only real career in math was as an actuary for insurance companies, and that would involve living and working with numbers the rest of my life. I really wanted a field that would involve me more in being with people, working with people, helping people, and that just didn't appeal to me. So I applied to medical school and went to medical school. I went to the State University of New York Downstate Medical Center in Brooklyn, after which I went to Maimonides Hospital in Brooklyn for an internship and spent a year as a surgical resident at the Veterans Administration Hospital in Brooklyn. I then went into the United States Air Force, and when I came out, went into orthopedic practice and have been there ever since.
Well, thank God you made that decision, Dr. Friedland. I'm sure I speak on behalf of thousands and thousands of patients in northern New Jersey and the tri-state area that have been so blessed to call you their doctor, and that you made that decision to go into orthopedic surgery. With respect to that, how would you say that your clinical practice has changed over the past 55 years or so?
Well, I think the practice of medicine in general has changed, and mine with it. Initially, I was a general orthopedist. In that era, we did everything. We treated and operated on hands, on backs, on shoulders. Whatever needed to be done, we were there. There were no subspecialists. Now, of course, we have subspecialists who can do far more sophisticated and complicated procedures than we could ever have dreamed of. In addition, the surgical procedures that I did in that era are now archaic. We do maybe if we did 10% of these anymore, this would be unusual. Everything is newer and far more sophisticated and gets much better results.
Yes. Along those lines that you're speaking of, where physicians are becoming more and more specialized, the field of orthopedics is becoming more and more specialized, as you have mentioned. I don't know of really too many other doctors that are still practicing general orthopedic surgery. Most of them are fellowship trained specifically in one area, and that's really what they focus their practice on. Along those lines, having been in practice for over 50 years or so, you've witnessed some major orthopedic technologies and breakthroughs over the years. Can you speak about some of those major advancements that you have appreciated over the years, for instance, in the area of sports medicine and arthroscopy and total joint replacement and fixation of fractures, for instance, among others?
Actually, everything you've mentioned is new. Our concept initially, when I was initially in practice of fixation of fractures, was basically you put plates on, could put rods down. Now the sophisticated methods of treating fractures with external fixators, with compression plates, with dynamics fixation, with even splint fixation, where you don't even put anything in, you allow the splint to really control the fracture, is all new. Arthroscopy was unheard of. Operating on a joint with a tiny little hole, unheard of, unthought of. There was no such thing as joint replacement, elbow replacement, hip replacements, knee replacements, shoulder replacements now, unheard of. Spine, if someone had a herniated disc, we would just go in and take out the disc, take out bone, take the pressure off the nerve. That would be considered the best procedure. Now we can use screws and rods and really do a wonderful job on recreating a stable, functional spine. Mostly every aspect of orthopedics has advanced and evolved over this time.
How would a surgeon, for instance, like yourself, who had no formal training in some of these procedures like hip replacement, knee replacement, or arthroscopy, start to begin to dabble in those fields with the new equipment in order to improve their own surgical skill set so that they can offer the latest and greatest technologies to their patients?
This became a real issue. When you're in active practice, you can't just take off 6 months or a year to go on a fellowship training program. You have to do it literally while you're practicing. So I would assist surgeons who had been trained in arthroscopy and learn how they did it. I would work with them, and then they would work with me, helping me learn until I became proficient in doing the procedure as well. I was able to take a week off and go out to California, where I learned how to do a knee replacement from the man who developed it, Leonard Marmer. And I came back and was able to start to do these in northern New Jersey. In fact, I and one other doctor were the first to do knee replacements in northern New Jersey. It became a matter of learning on the fly and picking and choosing times where you could actually be trained to do this.
Did they have cadaver labs back then, like they do today?
Yes, they certainly did. And when I would go to an academy meeting, I might sign up for one of those cadaver labs and work on that too, yes.
That's great. We'd hate to think of patients being the guinea pigs, right?
Oh, absolutely.
I remember the days of skeletal traction. Do you remember those?
Absolutely.
You rarely, if ever, see patients treated definitively with skeletal traction for long bone injuries and spica casts and things like that. You spoke before, referenced the Sarmiento type fracture brace, which is rarely used anymore. Surgeons are becoming more and more aggressive as technology improves and are leaning towards treating things that were traditionally treated very well and successfully non-operatively, now being treated with surgical intervention because of technological advancements. In general, as we know in our field, we like rigid fixation and early mobilization. So a lot of times when we can perform operations in a minimally invasive manner, achieve rigid fixation to allow that joint or patient to mobilize early, those are some of the major advantages to surgical intervention. Faster healing, lower risk of complications from being sedentary and immobilized, less stiffness, and improved function and return to function in general. So, certainly the vendors, the companies out there have helped us help our patients get better faster, and the field continues to evolve, and it's something I very much appreciate in our field of orthopedics. On that note, considering how surgeries and technologies have changed over the years, can you speak a little about length of stay? I remember the days when I first came out where total knees, for instance, would be admitted to the hospital for a minimum of 3 days, often up to a week. We'd round on these patients every day. We would get social services involved, physical therapy involved, a case manager involved, the families involved, and we'll discharge them to rehab facilities. Nowadays, that's rarely, if ever, done. Routinely, we're doing at the Kale Orthopedic Center, we're performing outpatient shoulder replacements, hip replacements, knee replacements, ankle replacements. Patients are often home in the luxury of their own environment within 4 hours of surgery, walking around, moving around, and very functional. Rarely, if ever, do we send anybody to a rehab facility anymore. Can you speak to some of those changes that you've seen over the years with regards to length of stay?
Oh, absolutely. When I initially was in practice, the concept was let the person lie around until they heal and don't risk damaging what you've done. So if we took out a meniscus, we'd have the patient in the hospital for a week until they could raise their leg in the air. The leg was in a cast at the time or in a brace, which kept the knee from moving at all. And then at the end of the week, the person left the hospital. They were pain-free, but for that week, they had used nothing of their muscles, and they were probably worse off than they were right after surgery. With their backs and their necks, same thing. Treatment of choice of a herniated disc in the neck or the back was traction. Traction for a week in the hospital. Lying in bed for a week, their muscles became more weaker, they became less functional, and they came out, again, no pain, but physiologically far worse than when they went in. All this has evolved. People are not admitted for traction anymore. They're started on a rehab program to get them back to function as quickly as possible.
That's incredible. It's just to think about the financial impact that had on this country, the cost of healthcare. Clearly, it's obvious to us all now why healthcare in this country is in a crisis, where there have been year after year after year declining reimbursements, where unfortunately physicians are suffering from increased overhead year after year after year. But that must have been incredibly expensive back then. I can understand why we're in a crisis right now. Regarding that, what about the doctor-patient relationship? I can only imagine that the doctor-patient relationship has taken a hit over the years. With all these rules and regulations from the government, HIPAA privacy laws, documentation requirements from insurance companies to obtain eligibility to intervene as a doctor to provide care to our patients, injections, x-rays, MRIs, physical therapy, surgery. All of these have greatly impacted our time with the patients. You know, years ago, the government enacted these rules and regulations and laws about having an electronic health record. I see doctors and physician assistants spending more time documenting notes as opposed to having face-to-face interactions with our patients. Clearly, that has deleteriously impacted our ability to forge a strong relationship with our patients that's built on trust, respect. I think physicians used to enjoy a much greater reverence than they do today from the patients. Nowadays, unfortunately, in many practices, patients are just a number. Doctors are doing high volume to try to keep up with the costs to run a practice because of these demands. You know, patients are seeing more and more second opinions and third opinions because there is no doctor-patient relationship. Years ago, what the doctor said was worth everything to that patient. The patient trusted the physician. They did exactly what the doctor said. There was a tremendous amount of trust and respect in that relationship. And more than likely, it's probably led to less risk of malpractice claims because doctors didn't have to practice defensive medicine. There was a wonderful relationship there where patients understood that medicine was not an exact science and that we all took the Hippocratic Oath to do our best to take care of these patients. How have you seen changes in that doctor-patient relationship yourself over the years? Because I remember even 25 years ago, you and I were walking around the office in Ridgewood, dictating very short notes, spending most of our time interacting with our patients face-to-face, forging such relationships. And now, most of the time, providers have their backs turned to the patients and they're talking to a computer instead and making sure that they dot every I and cross every T in order to satisfy insurance companies that we can actually bill for this encounter, or provide documentation where the insurance companies will provide authorization to get an x-ray or an MRI or a CAT scan or a surgery or an injection because the eligibility requirements have been met. What have you seen over the years? And would you like to elaborate on that at all?
Well, I've seen exactly what you're describing. When I initially was in practice, you went in, you saw the patient, you spoke with the patient. And the history you get from the patient in the patient's words is probably the most valuable part of the evaluation. It's not, a patient will say, oh, I've got pain in my knee, or I've got pain in my leg. That doesn't really tell you anything at all. First of all, you want to know what type of pain. Is it a sharp pain? Is it a dull pain? You want to know whether it's localized to that area or whether it comes down to that area or emanates from that area. Is there any associated weakness, numbness? There are all different things which give you a major clue as to what's going on with the patient. Most of the time, by the time the patient has told me their symptoms, and I've listened and I've questioned them relative to their symptoms, I know what's the matter with them even before I examine them, because most conditions have a very clear pattern of how they present themselves. Nowadays, the doctor is so pressured that they have no time really to do this because they're going to have 5 or 10 minutes of paperwork filling out forms when they're done, and there are more patients waiting. The volume of patients hasn't decreased. If anything, it's increased. So the amount of time you can give any given patient with any given problem has greatly diminished. So where does it get cut off? It cuts off in the history. You have pain in your leg? Fine, let's take a look. That doesn't really do much in the way of diagnosing what the person has. So there's been a huge difference in the ability of the doctor and patient to communicate effectively for treating what people have.
It's quite sad in a way. On the other side of the coin, in our own practice, it's taught us to be much more efficient. You know, we have to be efficient because we can't compromise in healthcare. We can't cut corners. So they're just much shorter interactions with our patients, but we still have to get to the point, listen to our patients, formulate that differential diagnosis, and nail it. We can't make mistakes in medicine. It's just, there's very, very little tolerance for that. So it teaches us to be extremely efficient, good practitioners, and still maintain the ability to do high volume and deliver excellent orthopedic care. With regards to what you were describing, you know, we're all taught in medical school that 90% of our diagnoses can be made just by listening to our patients. We're all taught that. And it's something I'll never forget from medical school. And I think about that every single day that I'm talking to my patients and every single day that I'm talking to our physician assistants. I cannot instill that enough in their minds that they need to just listen, because patients know their bodies way better than we know their bodies. And so that brings us to what we all know as healthcare providers, the SOAP note. There's an acronym called the SOAP note. And for those of you in our audience that are listening that don't understand what the SOAP note means, the S stands for subjective, the O stands for objective, the A stands for assessment, and the P stands for plan. So when we interact with our patients during a doctor-patient relationship, during that encounter, we're taught to have the patient present their subjective complaints. First, they'll offer us their chief complaint, what's bothering them today. And then they'll discuss with us the history of the present illness. Today, Dr. Cahill, I'm here for my right knee pain. I injured my knee playing soccer over the weekend with my son. I heard a pop. It swelled immediately. I fell to the floor. I couldn't get up and walk on it. It's been swollen ever since. It's been very, very painful, and it's been feeling rather unstable. I've been icing it over the weekend, and I'm here to get this thing evaluated because it's really uncomfortable and stiff. So that's an example of a history of the present illness where the patient is giving us the story behind how the injury occurred, what made it better, what made it worse, and why they are here today. The next part of the acronym is the O, the objective examination, where a physician like myself will perform a physical examination where we'll focus and hone in that body part that patient is complaining of. We'll do specific physical examinations that are focused on coming up with a diagnosis. All along, as we're listening to the patient's history of present illness and doing our physical examination, we're formulating in our own minds a differential diagnosis. It's probably this, this, or this. The objective part of the physical examination is further backed up by imaging studies. Imaging studies can include x-rays, CAT scans, MRIs, bone scans, etc., laboratory work, etc. And then finally, we get to the A and P portion of the SOAP acronym. The A is where we make our final assessment, and our P is the plan. What are we going to do to address this medical condition? So this sort of brings me to my next question to Dr. Friedland. We've spoken earlier today about technological breakthroughs and advancements in the field of orthopedic surgery. One of those major advancements comes in the way of advanced cross-sectional medical imaging, such as CAT scan and MRI. And I'm curious to know, Dr. Friedland, when this technology was introduced into your practice and how it impacted your ability to make these definitive diagnoses.
Well, when I initially went into medicine, the only radiologic studies you had relative to orthopedics were x-rays, pure and simple. You could get if you were looking for a herniated disc in the back, you would need a special spinal x-ray called a myelogram. But what did a myelogram involve? It involved initially, when I first went into practice, injecting Lipiodol, an oil-based dye, into the spinal canal, which you couldn't leave there. So after you got your x-rays, you had to take it out again. And that wasn't so easy, and it wasn't so painless. In fact, it was often as painful as any surgical procedure you would do afterwards. Eventually, that was replaced with an aqueous solution, which made it easier to get out without hurting the patient. But at the same time, this was still crude. It was invasive. Now, when we went on to CAT scans, you did not need to put any dye in. And with MRIs, you certainly did not need to put put dye in. A CAT scan we thought was a fantastic improvement because you could now see inside with what are basically slices, which would give you precise imaging of what you were looking at. And then the MRI came and made the CAT scan look primitive because the MRI gave a far more sophisticated imaging of different tissues. Then the various improvements in MRI, such that now the 1.5 and 3 Tesla MRIs give you such good definition that the early MRIs look like Rorschach tests. You can read anything you want into them. So the sophistication of radiology has come a huge way. If you're concerned about tumor, you can't see it on an X-ray unless there's been approximately 40% destruction of bone. Now with an MRI, you can see it even in its earliest stages when you're at a curable stage and where you can get it out and get rid of it either by surgery or radiation or chemotherapy, whatever, long before it has reached a life-threatening situation. So the advances are absolutely enormous.
Incredible. Incredible. I couldn't imagine practicing today without this high-resolution cross-sectional imaging that we have available to us. I can only imagine that in the past, you either treated patients way too conservatively when they really could have had a surgical operation to fix their problem, but without the ability or the technology to formally make that diagnosis, those patients were treated all too conservatively without much relief. Or, on the other side of the coin, potentially, you had to do more and more exploratory operations because you thought maybe the patient had a meniscus tear or thought maybe the patient had an ACL tear or a rotator cuff tear or a labral tear, but you didn't have any imaging modalities to confirm that.
100% correct.
So it just both of them in both formulas leads to and yields bad patient care.
Yes.
So thank God for this improvement in orthopedic technologies, which actually makes me think a lot of the arthroscope as well, because the arthroscope, at least if you're going to do a procedure, you're not filleting the patient open. You're not filleting that joint open just to put your eyes in there to explore to see if the patient has this torn or that torn. Nowadays, and with the introduction of the arthroscopy, through tiny, minimally invasive puncture sites, it afforded us the ability to put this long arthroscope into a joint to look inside the joint with high-resolution imaging abilities to do sometimes what we would call a diagnostic arthroscopy. Now even diagnostic arthroscopies are rarely, if ever, performed because the high-resolution cross-sectional imaging is so good that we have, for the most part, the ability to make definitive diagnoses before proceeding with surgical intervention, even with the arthroscope. So technology is an amazing, wonderful tool that we use in orthopedics, and believe it or not, it continues to evolve day after day after day in this amazing field of orthopedic surgery. I'm just going to shift gears a little bit, Dr. Friedland, right now. I'm curious to see how you feel about the evolution of the medical practice model in orthopedics. Years ago, clearly everyone would finish their training, their residency, their fellowship, and for the most part, either go into academic medicine where they are heavily interested in research at academic institutions in the field of orthopedics, or they would go, for the most part, into solo practice. You would be a solo practitioner, you'd start your own business, you would work hard, take a lot of call, build your name and reputation and patient loyal following. Nowadays, you don't really see much of that anymore. These doctors that are finishing up are for the most part, joining health systems or very large groups in employment models. The days of the solo practitioner or the practices where there's 1, 2, or 3 orthopedic surgeons in those groups, virtually non-existent anymore. The philosophy is, and this really goes back to our prior conversation, the philosophy is we need to have strength in numbers. We need to have leverage against hospital systems, against insurance companies, and the only way we can negotiate good rates so that we can actually get paid well for what we do, because overhead continues to increase, is to have strength in numbers. So you have to be a big group. You have to have a large number of providers, or you join a large health system, or again, choose to join an employment model in a hospital system, which is, a lot of times focused on orthopedic research. Is this something you've appreciated over your career, and how do you feel about that?
Well, I think that's exactly the pattern that has evolved. When I started practice, most of us were fiercely independent. We wanted a practice, our way, pure and simple. I remember when I first went into practice, the man I ultimately went in with wanted me to join him. I initially told him, no, I want my own practice. And then I reconsidered. We discussed further, and I wound up going in with him and have never regretted it. It's a whole different concept now, and I think subspecialization has become a big part of that. When I first went into practice, we did everything. We did hands, shoulders, knees, backs, hips, you name it. If it was an orthopedic condition, we evaluated it, we treated, and we were trained to operate on it. Now you have subspecialists who do far more sophisticated procedures in each of those areas, and no one person can do this and follow the pros and cons of different aspects of treating those areas. So groups become almost essential to giving good medicine. A patient comes into a group practice, and the doctor who is best able to treat that will be the doctor who treats it. There are many surgical procedures that a general orthopedist can do regardless of where it is. But there are some very sophisticated procedures which require someone who's had special training and special education in doing so.
Yeah, the orthopedist, as a general orthopedist, the orthopedist was almost like the primary care doctor of the entire musculoskeletal system back then, right?
That's exactly it. Right.
Now people are finishing up and they're a shoulder specialist or they're spine specialists. It's sort of sad in a way because what we do is largely non-operative. Every once in a while, we'll indicate a patient for surgery, but we treat so many musculoskeletal orthopedic problems non-operatively. And I enjoy that. I love the whole musculoskeletal system. I like taking care of necks and backs and shoulders and elbows and hands and hips and knees and even the foot and ankles. So the whole patient and being the quarterback for that patient. And, it really, throughout my entire career, forced me to attend the academy almost every year of my career because I needed to know everything about every body part. Yes, I did focus more on sports medicine and arthroscopy and hip and knee replacements, but I still treat the entire body. And that's one of the things I was most passionate about in this field. You get to be almost a primary care doctor of the musculoskeletal system. When people hurt their back or their shoulder or their hip, their knee, they don't really call their internist. They call their orthopedist. And most of what we do is just quarterbacking their care, taking care of them, getting them into physical therapy or chiropractor or acupuncture, and if they did need surgery, we would do that as well, which was the beauty of having, I think by being a general orthopedist and taking care of every body part, you got to see those patients more and more often, and it really helped establish that doctor-patient relationship, which is not there today. People, for the most part, patients will go see a specialist only for that thing, and then they're done with that doctor, and they'll go to another doctor for this or another doctor for that body part. I don't like that. That's not what I grew up with. That's not the way I built my practice. And that's why I've had so many amazing relationships over the last 25 years. And I'm sure you can say the same over the last 55 years. And that's the part that I sort of don't like about the specialization of orthopedics. Yes, I agree. Sometimes we need experts. But for the most part, a lot of us general orthopedic surgeons have done thousands and thousands of these operations that we've become experts ourselves, but we're not specifically only trained in that body part. So that's interesting. And we all know that medicine is not the perfect science, right? It's not a perfect science. I feel that in 2023, we can all agree that we sort of live in a rather litigious society. I don't know why that is, but it's a rather litigious society. I imagine a time, especially when you were in practice, when that doctor-patient relationship was so deep that a patient wouldn't even think about suing their doctor. Mistakes happen. We're human. We all took the Hippocratic Oath. We all vowed to do our best to first do no harm. But medicine is not a perfect science. Things can happen. Patients can have pain. Patients can get stiff. Sometimes patients' bones are weak. You can potentially witness a fracture during a procedure of a very weak, brittle bone. Patients bring a myriad of comorbidities to the table: obesity, smoking, steroid usage, which by definition increases risks of complications. How has the medical legal climate evolved over the past 55 years? What have you witnessed?
Well, I think, again, you've hit it right on the button. When I initially was into practice, you knew who your patient was. They knew who you were. You spent time talking to them and listening to them and then explaining to them. You had the time to do it. You didn't have 10 or 15 minutes of paperwork to fill out afterwards or dictate while patients were sitting and waiting. You could see your patient, talk with them, dictate a short note, move on to the next patient, and treat them. Time is not there anymore. Time becomes basically more valuable than anything, in that if you give this patient this much time, sooner or later someone else is going to get so much lesser time. As a result, relationships have diminished, and people look upon their doctor as a vehicle rather than as a person, and doctors tend to reciprocate, some of them, in many ways in that regard too. Doctors become just more defensive. They go ahead and they order tests because not that the patient may really need the test, but that someone, if the result is not ideal of what they're doing, no one will say, why didn't you order this or why didn't you order that? Because you have ordered it. Whether you really need it or not is almost irrelevant. And I've seen this type of defensive medicine grow and grow over time. Surgical procedures. In the past, we did what we really felt was going to be the best procedure to get the person really where they wanted. It may have had some risk. It was discussed with the patient, but everyone agreed and you felt comfortable doing it. Now you don't even mention that procedure because you don't want to do anything that has risk, because if it doesn't work out, you're going to be challenged as to why did you do it? You shouldn't have done it. You should have used better judgment. You deserve to be sued. You're going to be sued. It just is a whole different attitude and approach.
Scary stuff, scary stuff. So, in that regard, even in this milieu, even in this environment we live in with declining reimbursements and increasing overhead and the society that we've just described, a potentially litigious society, I know you and I both know that if given the opportunity today, we would make the same decision to go into healthcare and specifically orthopedic surgery, because there, in my opinion, there is no more rewarding and prestigious and honorable field in medicine where we get to appreciate on a daily basis that instant gratification of changing a person's life for the better. I've always said that I love orthopedics because, number one, it's always evolving. Technology is always improving, and I love that about orthopedics. But we're also not dealing with chronic disease. I like to help people and to make them feel better and enjoy the quality of life that they deserve regardless of the age. And sometimes in other fields in medicine, those physicians unfortunately don't have that luxury to be able to fix them or cure them of a condition, but rather they just hold their hand dealing with chronic disease that is never going to go away, and they just deliver palliative care to those patients, and that's necessary too. But for me, I need that instant gratification. I need to change a person's life for the better immediately and see it and appreciate it, and it's very tangible. Like you said, you can almost touch it and feel it, and that is something that is so rewarding, and I wouldn't trade it for the world. Regarding that climate that you so eloquently described, what advice then would you give to a physician who's about to encounter a relationship with a patient when he or she goes into that office to interact with that patient? What sound advice would you give that physician to become a better doctor?
I think the best advice I could give someone is look upon it as if you were the patient. What would you be wanting that doctor to ask you if you came in with this problem? And then you approach your patient the same way. I think that if we think in terms of how we would want to have our condition evaluated and treated, if we had that condition, is the best guide to how we should be really treating our own patients.
And what about to our patients? A patient that's about to come into a doctor's office, what advice would you give to a patient that's about to interact with a physician?
I think I would tell the patient basically, be your own advocate. If you don't feel the doctor is getting at the real root situation, if they don't really understand what your condition is, what your needs are, what you're trying to get at, what you're trying to correct, try to guide him or her in that direction. If you don't feel you're able to do so, change doctors. Go to someone who does understand, because if they don't understand what you're doing, they're not going to get the right answer in treating it.
Sound advice, very, very sound advice, and that comes from a wealth of experience, expertise, knowledge, and wisdom. And speaking of wisdom, because I want to seize this opportunity that we have with you during this short podcast, and I would just want us and our audience to glean as much as we can from this conversation with you, Dr. Friedland. Is there anything you can share with us about the wisdom that you've gained over your 55 years of practice? That is incredibly, incredibly impressive, an unbelievable accomplishment. Is there anything that you can share with us to just improve the quality of healthcare in this country, improve the relationships that doctors have with their patients? Because I know we focused a lot on the doctor-patient relationship today, and our ears are open.
Actually, It's a very simple concept. It's an old concept. It's an old saying. Do unto others as you would have them do unto you. Care for people as you would want to be cared for. Think of them as people, not as part of a practice, but as individual humans with lives and families and needs, just no differently than you would want to feel yourself with a situation reversed. And I think if you do that, you will get the most satisfaction you can over everything you are doing over your lifespan as a physician.
Well, those are words of wisdom, beautiful words to live by, and I will treasure this interview with Dr. Friedland my entire rest of my career and life. It's been an honor, privilege, and blessing to work with you alongside of you for the past 25 years. You've been a mentor to me, someone that I very much have always looked up to and respected, and I would not have considered anyone else to be my first guest on the Kale Orthopedic Center podcast. And it's just a blessing to me that you spent this quality time with me. And I really look forward to sharing this podcast with your wife and your children and your beautiful grandchildren. And may this be something that they will treasure as well for the rest of their lives as well.
Thank you.
Thank you so much.
Thank you.